What was it about the Indian health system that prompted you to look at doing quality healthcare in India and that too in Kerala?
I had opportunities to go around in the world and also work in healthcare in various places, advanced countries.
So, doctor, what was missing when you saw healthcare around?
Yeah, I think we lacked many things in healthcare compared to the outside advanced world. And it was not, we always blame lack of money, and that's why we are not doing these things.
Did you learn from your patient?
I learned a lot from the patients, and every patient tells you a story. And if you have the ears to understand and listen, and then you are a learner all through your lifetime.
Over the last 5 decades, how is the patient changed? What is the patient expectation, evolution journey?
There's tremendous, changes in all fields of life, all walks of life. So certainly it's bound to occur in healthcare also.
My first question is, now that your network is a part of a very large healthcare company and you're a part of 10,500 beds post the proposed merger, thousands of doctors. So there are 2 questions that come to my mind. And if you have 6,000 to 8,000 doctors, how do you really ensure that the patient gets to see the right doctor? Because so many doctors, I'm sure you have multiple cardiologists, multiple orthopedicians. So how do you really ensure that the patient is seeing the right doctor? I'm sure the patient has a preference, but if not, how do you get them to the right doctor? And also touch upon some of the capabilities, the clinical capabilities that KIMSHEALTH has developed, which are today class leading in the country.
Yeah. 2 aspects to that question. And the first one is our guest to see the right doctor. And actually, many times in the initial stages, the receptionists have referred patients to very, very wrong specialties and all that happened. And after that, we started a system by which, all these people are given continuous learning and, training and development. And that continuous training and development make them orientation and they are well oriented to specialties at the moment. And that system, even the CEOs and the COOs and the CFOs, everyone takes classes for all the people down the line. And so they know the specialties which have come and so also the equipment which have come. And so these people at the reception, at the ER, at the OP should know what we have. And so this continuous teaching or training and development has tremendously helped. Then the other factor also, of course, if there is a turnover of employees and staff continuously, even the biggest system can really defeat it. However, we always look at the retention as a major factor. So 10 years, 15 years, 18 years, 20 years is the kind of retention we have. So we should also focus across our organization that kind of a retention, and that retention will add value when you are giving continuous training and development.
Awesome. So there is a method to the madness.
Yeah.
And I think that is why your hospitals are one of the best hospitals in the country.
Yes.
So I wanted to understand from you, what are the clinical specialties that you have developed that are class leading today in the country? See,
this is a question I have faced many times in many platforms. Whenever I say about the specialty, my other colleagues will complain, you projected liver transplant and not the other things. So basically what we have done is that we have integrated the basic foundation very strongly, and so the clinical specialties are built on that foundation. And what is that foundation? And that foundation is academics, and which gives you knowledge across. And second is ethics, and we do not really falter in the matter of ethics at all. And the third thing is the quality part of it. So quality and patient safety. So this is the basic built-in strength of KIMS, if I say, to answer a question in a different way.
Fantastic.
Yeah. And then, of course, many niche specialties, most of the hospitals may have it, but we have kept it much more, orchestrated it very carefully and choreographed it so that the patient safety, all factors remain not as a talk or as a theory, it is really a practical. And one factor I would always like to, credential and privileging. We strictly follow that, and all our systems follow that, but credential and privileging, people are allowed to do a procedure only if they are very documentedly approved to do that. And so that ensures 70 to 80% of the patient safety.
Very interesting. You spoke about credentialing, you spoke about the clinical talent that you have. So with as vast a network that you have, and I'm sure there are a lot of clinicians, the culture of learning that you spoke about for the administrative side, please talk a little bit about the culture of learning and how a junior doctor is able to learn from a senior doctor and work as a team in the KIMS environment.
Yeah. In India, if I say in general, one of the things which all we should try, and healthcare is lacking a bit, is the team building. And so by the team building, we certainly feel that many of these challenges can be met. And nobody should work in a department as a silo. If there is they should have a system by which, a work culture by which they have a morning meeting where they discuss the difficult cases which were admitted last night. So the juniors learn, the seniors really interact, and so they exchange their ideas and the patient benefits. We have a medical board system, and so that specialists of different departments concerned with this particular guest who has a complex disorder, and they would meet together and they discuss, and then only they make a decision for the patient and share with the relatives, explain it in very ordinary terms, and they will be part of the decision. So many medico-legal problems, in fact, we have got very low medical legal problems or medical legal cases. So I think these activities are very simple to do, and we can spread across in our systems, and so this will be, the dividend is great. I will say that the dividend is very rewarding.
So doctor, let me also get to a little bit of a comparison with some other hospitals that I see. A lot of hospitals today believe in marketing. You'd see that they're talking about this gizmo, that technology. Somebody's talking about a robot, somebody's talking about a new kind of a linear accelerator. But I've seen you and KIMSHEALTH talk about different things. Things like patient safety, patient outcome, and more importantly, you talk about consultant availability 24 hours in 9 specialties. So tell me, why is it that you talk about these things and not just technology? While KIMS has every bit of that technology, but you've never really tom-tommed about it. You've always spoken about outcome, and you've spoken about consultant and clinician availability. So tell me the rationale behind that way of communication.
Yeah, that way of communication is because today healthcare is spending a lot of money, and even our GDP spending in healthcare is low, but it is going to increase. So if you look at the infrastructure, you can make a very beautiful infrastructure. If you look at the equipment, you can buy anything you want to, because money is the only issue. But what you cannot buy and what you have to have is the patient safety, the accessibility and availability of doctors, and not just doctors. It is competent doctors for that specialty. And so we have made sure that it's a bit of a difficult game, but we have made sure that all the doctors are full-timers here. They do not practice outside. And probably many hospitals will have the same kind of culture. But more than that, in 7-8 high-risk specialties, we certainly make sure that the consultants, no one less than the consultants stay in the hospital. It's not on call. They stay, night stay, and during the day they are of course available. And then night stay also, about 8 specialties they say. For example, emergency room, critical care, and neonatology, OBGYN, and all these specialties are internal medicine. Internal medicine, we have one of the unique systems called a hospitalist system. The internists stay in the hospital. As I mentioned that, the availability, accessibility of doctors are very important for patient safety as well as for a competence in care. And therefore, these measures have improved the patient's satisfaction, patient safety, and as well as the patient experience. And so that's how we formed the system. And it's a bit difficult, but with a good effort, we can all follow this.
That's fantastic to hear, Dr. Saab. I've always wondered what happens in the night, because I've truly started hearing this term doctor on call quite often these days. And I used to I lived in various cities, and every city has a different practice. But it is incredible to see. And I think I want to emphasize the statement that you made, the 9 different specialties where life matters the most. And when it matters the most, the clinician will be there waiting at the hospital for the patient to arrive. So that's, I think, a very big commitment. And I think it goes well beyond any other advertising or advertisement around technology or infrastructure. So kudos to you to have created that level of culture amongst the clinical fraternity. I think there's another pain point that I'm sure our audience would like to listen. We've always seen a huge degree of migration in the Indian subcontinent for want of better healthcare. You are a pioneer who's actually decided to go into lower tier cities, if I can call it. India is categorized tier 1, 2, 3, 4, and you are someone who's taken the bold call of creating fantastic infrastructure in tier 2, tier 3 cities and have made them work exceedingly well. How do you ensure, 1, clinician availability, 2, you're able to deliver the same level of complexity, because it's far and wide in the lower tier cities as well, and of course the same level of quality?
Yeah. I think this is an important question we have to answer in the national level, because today, the metros have got very good facilities and hospitals and all that. But I feel that our country really needs the kind of tier 1, tier 2 and tier 3 cities at least should have tertiary care facilities. And that's what is required today, because everybody cannot go and get it in the metros. And this will make, the care much more affordable, number 1, for the people, because they are receiving at their doorstep a quality care, or a transplant happening just near their house. Certainly it will bring down the cost for them. And second, their family will be comfortable accompanying them. So in many ways, this is an important step all healthcare organizations have to adapt. How we do and how we maintain the quality in the tier 2 and 3 cities or towns is a question which we have to carefully analyze. One thing is better today is that availability of competence is better. So as long as you have got hub hospitals and flagship hospitals, you can take these competent people and train them for a few months or even a year. And so it should be a planned program. And after that, you send them to tier 2 and tier 3 cities, and they will impart the same quality. And there will be always a connection with our flagship hospital to the strategic business units. And so that way we can maintain. Then we have got group, coordinators, we call it. That means group head of departments who will be not only functioning in their hospital, but they at least a month they travel to these centers and make sure that the quality is there. And the support staff also the same. Doctors alone cannot make that change. The support the support system, like the technicians, the nurses, all of them should also be trained in the same way. And so we are not only doing a service to the nation, and we are part of the nation building, in fact.
It's fantastic to see, Dr. Saab, how brick by brick you've actually thought through every single element of care delivery.
Fortunately, even though we have not done anything extraordinary or anything, I feel that we could create a model. And now, I'm part of the bigger group, and we have created a model where this model can be really useful at large. And probably I will try to write a little bit more.
No, I think it's an incredible need of the country. Hiring today in India or across the world is difficult. While they all say that we have so many schools and colleges, but when you go out and find talent for our hospitals, it becomes very difficult. So how do you look for new talent? So one part of the clinical side is looking at the medical degree. But then there is another part of you, which I've been hearing today, is your social angle, is the community angle, is the patient friendliness angle. And all of us are wired differently as human beings. We may be trained, we may be educated, but there are other attributes that will define how we deal with the patient. So how do you figure this out at the recruitment stage of a clinician?
See, an interview is, I always consider as one of the poorest form of selection. And but at the same time, we have to recruit people. So we have set up in our system a kind of an idea that we will select only from some of the top colleges and schools in India. And sometimes it is very difficult to get that kind of a talent, we agree. But now more and more talent pool is available, and so we can continue to do that. And so I don't want to mention everybody knows the top 10 institutions. The important thing is that a good reference is required. Extremely rarely we go for a very high status star from the market to get it, unless there's a dire emergency. But we have all departments have got enough people who can support each other, even if one is going on a vacation or for a long leave. We also send people for training to institutions of reputed institutions in India. And sometimes we sponsor like 50% because they are going to come and work with you. So a number of activities have ensured a reasonable supply of talent and competency for us. And so this is a model we all can follow.
So it's a way of saying that you have produced your own stars who are extremely capable and focused on the patient. Would that be a fair statement?
That's very politely and with a lot of humility, I should say that I would like to accept some kind of your compliment for that.
Thank you, Dr. Saab. I think there's so much that we've learned today. There's so much we've heard today. Today, as I say, you're a living example of EQ and IQ, which is what the industry needs, which is what each and every patient is seeking today when we enter a hospital. 5 decades of an illustrious career, many lessons learned, lots of experiences lived, lot of recognition earned. How do you define hope today?
I think hope is the one thing which drives us. And hope comes in when there is uncertainty. And, life is full of uncertainty, and healthcare is full of uncertainty. And, but as a clinician, and even as a clinician who came into management, I always feel that we should continue to give hope and for our, I don't want to say our guests, not the customers. I will end up with a small story perhaps in this aspect. We had a patient, about 18-year-old girl, who was riding on the back of a motorbike with his brother, with her brother, and she was thrown off. Unfortunately, a bus which came across ran over her, and she was brought to our hospital. And the whole team of surgeons and doctors and all, she was run over the abdomen, and viscous rupture, multiple fractures, and nobody wants to touch her, all just conservative management. Her brother came to see me and said that, "Sir, please come and see this patient and try, help me to save the patient. She's my sister." So I went over there. I went to see her, and there was a panchayat president also of the local area standing there like this, "Please do something for her." So I called back all my, specialist team and sat together and said, "What can we do?" Everyone said that this patient will die on the table. And so we explained everything, and finally I said, "Please go ahead and let us operate her." One by one, a team of people for 12 hours operated. And finally, let me conclude the story saying that after 9 months, when we had the family anniversary, we call it KIMSHEALTH family feast or family fest, she danced in front of the tearful eyes of not only her parents, but also many doctors and many audience. So I think that is hope, and that is what I define as hope. And healthcare is a beautiful profession where you give hope for our community.
What an amazing story, Doctor. It won't be fair for me to drop tears, but the story is well worth it. To that hope that we continue to bring to you, these are stories that make healthcare, and these are stories that make people like Dr. Sahadulla leaders who we all want to look up to. Thank you, Dr. Sahadulla. Thank you very much.
Very obliged. Thank you very much. It's a great honor you invited me. Thank you.
हॉस्पिटल में क्या होता है, आपको क्या चाहिए, मानिए मेरी बात. We know it better than you. Do remember, like and subscribe The Hope Code.